It's easy to get lost. This is The Revenue Maze, and I'm Valerie Cobb. Join me as we navigate the halls, dead ends, and U-turns on your path towards upward growth trajectory. The Revenue Maze is sponsored by Revenue North Star, guidance and execution through fractional revenue leadership, uncovering hidden revenues, and empowering small business growth through process-driven sales customized to your company environment. Hello, everybody. Welcome to another great episode of The Revenue Maze. I'm super excited about this guest, and there's some fun, fast facts about her. You might want to talk about boxing gloves. She's a mom, and when you see her, it will be like, how does she have a 19-year-old? Seriously, how does she have a 19-year-old? And at the end of the day, she's extremely busy with all the mom stuff. But on top of that, she has a company that she is the founder and CEO of, Dropstat. Welcome, Sara Well.
Hi, thank you so much for having me. Yeah, actually, believe it or not, being the founder and CEO of a multi-million-dollar tech company is the easier part of my day. Um, Negotiating with adults is always easier than negotiating with teenagers, and especially now with Chat GPT, where they can use some really solid evidence against some of your discussions about when bedtime is or should be, and can create meta-analyses on why a bigger allowance can create a lot more self-sufficiency in the long term. So yeah, running the company is sometimes the easier part of my day. I love both. And boxing is fun too. It's pretty similar in some ways to some of the stuff we experience in the business space. You know, staying in the pocket even though you're nervous, and it's not about how many times you get hit in the head. It's about how many times you get up. So it's my exercise of choice, and very much compatible with how I perceive having to fight your way through the finance ecosystem, especially today in this economic environment, and how difficult it is really for a lot of startups in this space, particularly now.
Well, those are all amazing things, and everybody wants to hear about what you're doing with all of that. But we always answer one question first on this show, and that is, what is one thing that you can tell listeners and viewers that can help them get out of the revenue maze?
Yeah, I think one of the most important things is really sticking with your vision and objective. You're going to hear a lot of smart minds in the room tell you why your idea isn't good, why it can't monetize, why it's been done before, why the legacy incumbents in this space are going to win out at the end of the day. But we wouldn't have most of the innovation we have today if the founders had listened to that sort of feedback. So being smart and having experience in multiple other sectors or even similar verticals doesn't make anyone the authority on the value of your own contribution. So just stick with it, and it'll get done.
Well, that's very, very sage advice. And there's a lot of themes in there that people would naturally, when you're in the heat of the battle of a startup, that you might naturally want to give up, right? Because people have told you, hey, there's already this, and we all do analysis and everything. And we look at it and go, is it worth doing? Is it not worth doing? And then hanging in there. So give us some tips on how you hung in there, because I hear that this is a multi-million-dollar company, so you've done pretty well with it. So how'd you hang in, and how did you defeat the head trash group?
Yeah. Well, I think life gets really simple. For me, I'm lucky because life is really simple when you've worked in the trenches with the people that your product is trying to serve, namely nurses in healthcare, and when you've held the hands of the patients that you're fighting for. So I got really lucky because there isn't a day for me that goes by that I don't clearly see a visual of my 12 years in healthcare and the value that this will bring to the ecosystem and one of healthcare's biggest pain points. And I've always felt like it would be giving up on the back of my colleagues that I respect more than I can even put words to, and patients that have actually lost their lives due to process inefficiency, where had we had the right tools, we could have had better staffing ratios. We could have had more boots on the ground to recognize early stroke symptoms. We wouldn't have been too busy, caring for one patient to give meds on time on another patient, and we could have perhaps avoided a rapid heart rate and a clot. So for me, not, giving up isn't really an option. This is the healthcare system I'm aging into. This is a healthcare system everybody I love is aging into, and we can't be okay with that status quo. So I've always felt a tremendous responsibility to the vision and to the mission of this company, and I think I've seen that fire within so many founders that I've met, whether it's, we're an AWS accelerator graduate, whether it was in that cohort, whether it was at Startup Grind, where, we got a lot of our early start. So I think that passion is very innate to a lot of founders. I think that we tend to pedestalize the wrong opinions, though. I think we tend to put founders who maybe have done this 3-4 times on a seat above us. And when we try to get feedback and it isn't what we want to hear, we might accidentally give that too much credence. And to that, I would say you really have to protect the vision and mission that you hold for the product that you're trying to take to market, and understand that people are wrong a lot of the time. Even VCs who spend months in diligence on every portfolio company that they invest in have, what is it, a 9 out of 10 failure rate?
Oh, yeah,
So
it's very high.
the smartest minds in the room are wrong. Just stick with your intuition. It can't be as bad as 9 out of 10.
Well, and I love that. Now I've got to unpack a few things that you've been talking about, because some things are going to be very near and dear to people's hearts, including mine, especially with the healthcare system the way it is in the United States. It's not. I think it's a trial throughout the globe, but in the United States, I have recently had a loved one that that went 22 days in the hospital out of the last 45 since August 9th. And went into AFib and a million things. And when I say near and dear, that was my husband. And it was difficult. It was a very difficult experience. And as we talk about kind of what your technology does and how it makes things more efficient for the staff and those things, you can get pretty passionate about the needs out there. And there is a ton of needs, because I've worked in healthcare as well. And healthcare, everybody agrees at one point they're the most forward-looking, antiquated group, period. So they will definitely have stat after stat and not change. So it sounds like you're just pioneering a ton of change, which helps a ton with sticking to it for sure. So tell us a little bit about how you got into what you're doing with that, because you said
Yeah.
you noticed some
So
things.
I spent some 12 years walking through $10 million gardens and $20 million lobbies and these beautiful hospitals and health systems, and would go upstairs, and we were always short staffed, and we never had enough staff to meet the optimal safety needs of patient care, right?
Mhm.
And whether it was my unit or another unit, there was always a shortage of nurses. And this is before COVID, before 500,000 nurses left due to COVID fatigue, right?
Yeah.
So this is before the crisis was half of what it is now.
Hmm.
And it was kind of wild to me because we have gamma knife surgery, let's say on the 8th floor, and minimally invasive robotics on the 3rd. And the process we're using to procure staff, which is the labor operating system of healthcare, was call, text, wait, which is a good 20 to 30 years in technological advancement behind the rest of the care delivery systems we had. And it just made no sense. Like, why do we have facial recognition software in Macy's and we have lines and paper charting out, lines out the door of an ER? And why don't we bring that into our health systems and create process efficiency where it matters the most? It didn't make sense to me. And then I became a staffing manager and I saw firsthand how much worse that the existing technology was making our process. And we were manually calculating our staffing needs, which is error prone and takes time away from patient care. And the call, text, wait process didn't enable me to reach out to other units and departments within the same organization that had staff
Mm-hmm.
and where staff may have been available to work my unit and they were likely cross-trained, right? So let's say I'm working trauma surgical ICU, cardiovascular ICU, neuro ICU, burn ICU, and medical ICU are all cross-trained to work on my unit by policy.
Mm-hmm.
And there's a good chance someone there is available to pick up an extra shift on my unit, but I can't reach them. So policy enables us to share staff. The technology did not.
Yeah.
So net effect, we're going to these super expensive premium pay labor options where we're paying an extra $50,000 to $100,000 per head to do the same job. And there's actually people siloed within the organization who are safer and more cost efficient. We couldn't reach them. And it just didn't make sense. We were overspending by so much that we couldn't even recruit and engage and properly retain our own staff with the right, salary increases yearly and with offering better, dollar per hour shift incentive to hire and retain our own staff. It was like we were using so many band-aids to stop a bleed. We were never getting to that actual, some of the source issues causing it. Yes, there's a supply demand issue, but how much worse is that when you can't access your full option of resources? So it just felt like this is a scalable solution, right? And yes, we can't fix the entire supply demand inequity, but we could probably address a lot of it with better technology. And I started thinking, well, there are some days I get to work and I am floated to one of the other portfolio companies 20 minutes away within the same hospital system,
Mm-hmm.
meaning the ability to share staff within the same organization and then within a sister organization is allowed by policy and again not by technology. So it just gave me pause, like how massive is this issue? It can't just be this one healthcare system. It's got to be pretty extensive. Did market research and saw that the addressable market is massive, and essentially built the product that I wished I always had, where in the amount of time that it would take a staffing manager or charge nurse or scheduler to look up one phone number, we're able to 10 to 20x the size of your reach within seconds, automating the process of communicating open shift needs to internal staff, all cross-trained teams within the facility and then within the portfolio company that may be nearby, then reaching out to internal agency, internal float teams, and then we integrate with W-2 and 1099 marketplaces so that essentially there's an assurance that somewhere within that kind of waterfall of outreach, we are going to be able to fill that shift quickly, cost efficiently, and we send all that data back to staffing managers in seconds so that they can see, these 7 people are available to pick up the shift, and it's all cost tagged and it's all optimized for union compliance, seniority, safety, cost efficiency, and we're able to fill minimum 10 to 20% more shifts. Just using the technology with the cost tagging, we're able to fill those shifts at about 40% less than existing systems, and we're able to reduce agency and overtime premium pay labor significantly over the time of about 12 months. We're able to reduce it by about 50%.
Yeah. Yeah. Well, it's definite. It was. Well, it's still a problem, but it is definitely a great way to look at it. And there's a lot of other industries that already do similar things. So, meaning in their industry, not necessarily just in. I mean, the airline industry does something very similar, and so why not? Why not in healthcare for sure? And especially with that staffing shortage. I post COVID, it's gotten even worse. So I mean, the market is huge with that, and there was a bunch of traveling nurses recently. Like I said, if I hadn't had such a recent experience, it wouldn't be so raw. But I did feel for a lot because it did feel like that there were departments that, well, we can't grab from, even if it was allowed policy wise, they would literally say, well, we can't take from that department, and you'd see people just backed up waiting to get help, and nothing was happening. And so it's an amazing thing that you have set up, and it's definitely fun that you lived it and you built something that fit. And that's usually the great sign of a great product. I mean, it was something, hey, out of necessity, we need to build something that does something better. So pretty cool stuff. What's the future look like for Dropstat?
Yeah, I mean, well, a quick word um, on the travel nurse part of it. We're not eliminating any of those sectors. We just want to make sure that there's better and more equal distribution of those resources. What we're seeing right now is that even those available resources tend to coalesce around the UC systems that pay more, and we're going to lose the rural hospitals, right? Because as bad as it is now, we're expecting 1 million nurses to age out of the system, within the next few years. Essentially, if we set up all the nursing schools that we needed right now to ensure that healthcare doesn't collapse, they wouldn't be trained in time. And
Yeah.
you can have the best physician in the world, but nurses are the execution team, the executing team of healthcare. So if they can't carry out and deliver that care, I mean, the best neurosurgeon can't effectively operate if the post-operative risks are sky high because we don't have the right staff to patient ratios because of a massive shortage. So this is, a huge issue, and making sure that we don't leave the rural hospitals out of this equation, making sure that we can effectively communicate and get all available staff internally to be able to work and only utilize those resources when absolutely necessary, we can ensure that the distribution is sent out more equitably to those communities where otherwise they would really be left out. They might be priced out of being able to, afford the escalating cost of care. So that's a huge concern for us, where if we think that food deserts are scary, imagine healthcare deserts. Like, what would that do to the remaining healthcare systems, and what would that do to those communities? So in terms of our future outlook, our perspective is very much focused on how do we first ensure that we're effectively utilizing internal resources, that we can assure that we're not overutilizing external and premium pay labor, and then really looking at what's the engagement and retention like, right? We can't staff very well if there's high churn rates and if the burnout rate remains what it is.
Yeah.
What's wild is that, the nurses and physicians that are burning out right now of healthcare, it's primarily because of this pressure of being saddled with unsafe labor loads and getting essentially the same salary with minimal pay rate increases and being responsible for so much more. The conveyor belt works as long as you don't increase the speed by 2 to 3x, then it's scary to maintain quality. Like, these nurses and physicians are still practicing under the same licensure and being held accountable to the same standards of practice, even when they're taking care of twice the patient load. And it's really mind blowing if you think about it. We don't do that to pilots.
Yeah.
We, because you can't physically make them fly two planes at the same time, but somehow we think that it's okay to gamble like that with patients' lives. And there's so much data out there on what happens when you give one nurse an extra patient outside of published safe staffing ratios, right? We
Yeah.
know since the 80s that you get a 7% increase in mortality for every single patient that provider is managing, for each patient added outside of unsafe labor loads. And we see this in practice. We see that it's getting harder and harder to meet patient needs. Patients are a lot sicker. There's a lot more comorbidities out there right now. And if we don't do something soon to upskill, attract more people into healthcare, we're going to start seeing much longer wait times for simple things like seeing your primary care provider. And I'm sure you're seeing this already.
Mm-hmm.
Basic appendectomies can take months to schedule.
Mm-hmm.
Emergencies is basically the only way you're going to be seen anytime soon for most things because of the backlog and wait times and the inability to meet the needs of the aging boomer population. We're just outnumbered. And if you think about it, it's scary, right? If in the post-acute sector, the entire aging population is built on the backs of certified nursing assistants who get paid less than your Starbucks barista.
Mm-hmm.
And they're helping our entire elderly population with activities of daily living, walking, taking their meds, making sure that they stay mobile, avoid infection. It's not going to work.
It's a real tough challenge, to be sure. We could get into days and how, you know, I have a cousin who is a nurse, and we've talked about this quite extensively. And actually, when we talked about the traveling nurses and how some of them get paid more, we heard that, like, as a patient, we heard that from the nurses over and over again, how resentful they were of that. And they were resentful to the point of sometimes inaction for it. And it was a very tough problem, right? Because as as that inequality that you're talking about, you're right. The rural areas, they don't always get the best care because, well, what traveling nurse wants to go to the middle of nowhere? I mean, it's not part of what that sort of mentality is. Now, they were amazing, by the way. I'm going to applaud them up and down. In fact, they were, what can I say? They were by and large more skilled. I'm going to just say it right out of but they're also their bedside manner, the experience was amazing. But here is why I think that happens, because there is that resentment, but also that workload just gets piled, like you said. And at some point, you, if there's 10, I'm very mathematical. If there's 10 patients and there's only one person, somebody's got to wait. You can't say, okay, everybody can get treated all at one time and everything, because it's human. You can use tech to help increase your capacity, but and the only other thing is to add another count. And if the count isn't there, then they're going to be either waiting a long time or or they're, I mean, it just makes sense. It goes their capacity to do the best job goes down because there's only so much that they can do. And it's rough. It's definitely rough. I have friends that back in the day we were working through the Thrive campaigns that Kaiser Permanente had come out with, and we were talking about preventative care to try to help offset. Nobody wants quality of life is what people want, right? They don't want to actually have to need the help, but when they do need the help, they need the help. And the point is to have that kind of staff that isn't just dying under a load, that they can help. One of the physicians looked at my husband and said, "I am not going to operate today." And he asked the question, he said, "Well, why?" "Because I'm too tired." And it isn't necessary. And when you're too tired, mistakes happen like crazy. So I definitely am grateful to the healthcare community because it is a very difficult problem. And yes, studying the boomers and where they're at right now, and even some of the lifestyle choices for it, it has created a load for sure. So yeah, you're like in the perfect niche, because that is one of the ways to help solve that challenge. So fabulous stuff. So was your mom, your dad, have you been in healthcare your entire, like, did you grow up in it? How did you start? I mean, how did you go from boxing to healthcare or vice versa? Or maybe you just took out your frustrations in boxing. I don't know. How did you come to it?
It's a great outlet. Yeah, so my brother had a brain tumor removed when he was about 5. It was an astrocytoma, which is an anomaly. We don't really know why or how they show up, and it's primarily pediatric. And this was back before there was kind of a 2-person limit in the pediatric ICU. And we had a lot of family and friends that came to show support. And my little brother always had people around. But I noticed that there were a lot of babies in the unit. This is back before everyone had their own isolated closed door room. And it was kind of like a circle. So you really could see other patients. And I don't even think we had HIPAA forms then. And when there were too many people at our bedside, the nurses had agreed. I was about 17. They had agreed to allow me to help out with the other kids. This sounds awful, but nurses are not staffed for cuddles.
Yeah,
Do you know what I mean?
I do. I
There's
do.
volunteers in most hospitals that can do that, but I saw a lot of post cardiac surgery babies just kind of alone. So I made these little like mobile toys for them and kind of hung them up by their cribs, and the nurses started to let me hold some of the little kids and play with them. And again, this is back before I don't think our privacy ecosystem, the way it's set up right now, would allow some random visitor from one patient to go visit another patient. But it wasn't wild, back then, and
Yeah.
I loved it. And the tubes and the lines and the wires, and it didn't seem to bother me. And the nurses were all like, "Wow, you should really go into medicine. You should consider that." So here I am. I loved it, and to be quite honest, I miss it every day. I really loved trauma medicine, and I loved critical care medicine. I didn't leave because I was looking for an outlet. I left because I just found a much bigger way to contribute to what I really see as a life-saving product.
Sure.
I would say it's hard. Selling into healthcare is definitely not easy. As you said,
Mhm.
they're one of the slowest to change. And I think, part of the issue that's so interesting in healthcare is that the executives really don't have a great handle on the product that they're selling.
Mm.
Um, for example, if you're selling, say, Patagonia, you see the
Mhm.
jacket in front of you, you can feel the quality, you can feel the fabric, the zipper, the integrity. You can try it on and test it. We don't see that in healthcare, right? When the CEO gets hospitalized, they have a very different experience than everybody else.
Mhm.
So they don't totally know what their product feels like,
Yeah.
and what that patient experience is really like. So it's really hard, I think, to solve problems that you can't understand the way you can with a lot of, let's say, in the consumer space, right? In the e-com space. So, case in point, during COVID, there were so many health systems that would get on their LinkedIn and get on the news fully manicured, talking about how great the tent is that they, kind of had set up, etc. And um, if you look on Instagram, the nurses that worked in those health systems were saying, we don't even have PPE to keep ourselves safe, right?
Yeah,
So the dichotomy there is mind blowing,
sure.
where there's a marketing engine in so many hospitals and health systems that is entirely different from the patient care advocates who are the providers. And it's so difficult to bring solutions into a space where many of the the C-suite you would sell into isn't willing to admit that it's a problem.
Oh gosh, yes. Heaven, yes. Amen. It is one of the most, yeah. I think that at times it's, so I love the Patagonia where you can touch it, feel it, experience it, right? And I love that analogy because I in another life, former life, and teaching singing opera for 18 years and coaching it for 10, it was one of the best ways to teach how to actually connect with prospects or intangibles is what I would call it, right? Something that you can't touch. You can't you can put your fingers on a piano and you can see what the keys are and you have the eye hand coordination, right? But you can't, they have to learn to make a sound that they can't touch, right? They have to learn to do that. And what you're talking about is extremely important in that dichotomy that you're talking about with healthcare for the antiquated but not antiquated system, right? Because some of it is they aren't walking the path of the patient. And there's I don't know, what is it, St. Amsterdam or some movie TV show right now that is about a doctor's life and what he went through. And of course it's Hollywoodized, right? But at the same token, sometimes if they walked a mile in that shoe, then it wouldn't be so much of the business side of the fence. So you have the payers, right? And they're the very business side of the fence. And if you really want to get to the crux of it, then if you enforce the payers to then force the system to do what it needs, at the end of the day. But they're very much, I mean, after working, they're very much, it's a business transaction. And so the cuddles, I mean, you said, they can't cuddle. Well, we need that human touch. We need that ability. But when you have a staff that isn't permitted to even do that anymore, it's got to get through that patient, move on, move on, move on. And they don't they don't get that opportunity to even, sometimes I think when I was talking to some of my friends who are in nursing, originally they thought it would be the cuddles. They thought that they were going to be doing the things that helped with the interaction with the patients instead of just executing orders, give them this drug at this time and get them this food and all of these things, and don't make a decision, heaven forbid, this is my orders, make sure this happens. And the legal and regulatory side of the fence makes it so everybody goes, oh, yes, I will follow those orders anyways, because I've got also on top of it legal and regulatory that are causing me issues, because if I don't do that, then I haven't covered my butt, the CYA kind of thing. And at the end of the day, it's a tough problem. And I can see why you wear boxing gloves.
So much
But you
cheaper than therapy.
yes. But it is fascinating. So, Sara, this has been a very fascinating dialogue. What's the best way to get a hold of you, or your organization? Because you do need to get the word out. That's the key, is getting the word out so that it moves the slow moving machine.
Yeah. yeah, definitely. We want to get the word out, specifically um, helping the general population understand the role that staffing ratio plays in the safety of their own care, right? I mean, if you think
Mhm.
about it, you have more information about how clean the kitchen is at McDonald's when you want to go to a restaurant, and there's an ABC rating window, in the window, versus when you go to a hospital and there's this illusion and there's an assumption of safety. And how frightening is it that you may not be safe.
No.
You may be safe Monday and then not Tuesday. And it could be that,
Yeah.
you would stay with a loved one if you knew that the staffing ratio isn't safe. There's an unsafe number of nurses to patients on that unit. They're not required to disclose that, but it would be good to ask, because maybe you can stay and be an extra set of hands for your loved one and reduce their risk profile, right?
Yeah.
So, and then perhaps when there's a measure that comes across a ballot for um, safety in healthcare and enforcing safer ratios, the general public can get involved and have a say in their own healthcare delivery. And a funny thing happens when things are put into policy and when things are made law. Somehow they find a way.
That's
Yep.
true. 44% follow regulatory and legal stuff. When they get, we were talking about that because I have a client that's cyber risk, and one stat came across that was 44%. There's legal and regulatory come knocking,
Mm-hmm.
but, it's all about
Yeah.
data privacy, and yet 44% will adhere to it. The rest will go, oh, I'll take care of it when it happens. And they just don't. You'd be shocked, because I am a non-rule breaker, right? I am like, okay, if this is the rule, this is where we go, right? And then you come up and you realize with other humans in the world that that's not the case. It's like, well, I'll get to it when I get to it. And I think getting the word out is extremely paramount for that. And I think some of it will take some experience of, just enlightening the general population of these things. Because, yeah, they don't know always the rules when they go in to get help and care. They just kind of go, what do we do?
Agree.
And I'm going to definitely share this with my friend Monica, because she stayed with her mom several weeks. Anytime that her mom's in the hospital, she never leaves the hospital because of it. Same reason. She's nervous that the ratio is too high, and that the care, mistakes are going to happen. So, anyways, so do they
Yep.
go to LinkedIn to learn about Dropstat? Where do they go?
So we're on LinkedIn. We're on I'd say we're always available via email, info@dropstat.com, to
Okay.
figure out how to get involved. We sell into the C-suite. I would say from a revenue maze perspective, you can sell into these very difficult systems that are hard to get into. Obviously, if you can demonstrate good ROI, you will be able to get even into the most difficult sector. So I would say, stick with it, especially in healthcare. We need that innovation. It's going to impact all of us, and yeah, happy to be able to provide additional insights to any other startups or any other founders who need a little bit of guidance in this space. Just email us at info@dropstat.com.
Perfect. Well, thank you so much, Sarah, for being on the show. And thank you to the listeners and viewers. This has been another great episode. And I'm so grateful for all of this time that you have spent with us today, Sarah.
Pleasure.
Thank you all for joining another great episode. Hats off to all you small businesses out there. I can't wait for the next episode.